Hello, soon-to-be licensed nurse practitioners. I am Miss Cohen, and I want to welcome you to the Cohen Review. Now, the Cohen Review, it's intended to help nurse practitioners like yourselves study for the nurse practitioner boards, regardless which exam you're going to take, AANP, ANCC. Now, today's presentation is meant for two different scenarios. Either one, you are the nurse practitioner who graduated from school and you've been studying for some time and you like to assess how ready you are to pass the exam. Well, if at the end of today's presentation you knew all the answers, you felt very comfortable with everything that I discussed today, that may be a good indication that you're ready to test and sit for the boards. The other scenario is if you are still in school for nurse practitioner and you would like to get ahead and see what it's like to study for the boards. What are the questions made out of? What do they look like? What do they feel like? What kind of topics you should be studying? Well, for both scenarios, we have the Cohen Review, and we have a bunch of lectures and blogs and diagrams and videos to help you prepare to pass the nurse practitioner boards. But let's see how you do with today's presentation. Now, I'm going to present the question and I'm going to pause for about 3 seconds to give you an opportunity to think of the answer. But if you need more time, by all means, please press the pause button and take as long as you need. All right, our very first question, it's about STIs. You have a 30-year-old female who presents to your office with 7 days of yellow vaginal discharge, vaginal itching, and irritation. She is sexually active and does not use condoms consistently. On exam, her vagina is malodorous with frothy green discharge, and the cervix is strawberry colored. Which findings on microscopic evaluation should help confirm the suspected diagnosis? A, branching hyphae. B, clue cells. C, flagellated motile organisms. Or D, red blood cells. Let's review the answer, and it's C, flagellated motile organisms. Now, you are welcome to read the rationale, which I always give to all of my questions. But just give you a heads up that during my lectures, I also talk about test-taking skills and test-taking tips, because you will not know all the questions on the exam, but there are ways of coming as close as possible to the right answer by doing, for example, process of elimination, looking for the clue cells in the question that should make you think of the right diagnoses. So I make sure to go over all of those things in the Cohen Review lectures. All right, let's go to the next question. And just so that you know, during your studies, you should become familiar with the other STIs or sexually transmitted infections, which we're not going to cover here, but they are all covered in the Cohen Review. Syphilis, HPV, HSV2, chlamydia, gonorrhea, HIV. And you should not only know the treatment, but also the presentation, such as signs and symptoms to look for, and also diagnostic tests. For example, do you know which test we use to screen for syphilis? And if that test is positive, what else would you order? Do you know the proper terminology for the presentation of herpes in regards to vesicle versus bulle versus itchy, non-itchy, painful, non-painful? And in regards to HIV, you have to know what T cells are. What about the CD4 count? What if it's less than 200, what it means? All of these things are covered in the Cohen Review, and I welcome to check it out if you would like to further learn about these topics. Let's go to the next question. Endocrinology. A 24-year-old female presents to her primary care office complaining of excessive weight gain over the last year. She reports irregular periods and acne comparable to when she was a teenager. On exam, she has excessive fatty tissue on her upper back and dark straight hairs on her abdomen and upper arms. An overnight dexamethasone suppression test is ordered. What findings would you expect? A, decreased morning adrenocortical glucocorticoid level. B, decreased morning cortisol level. C, elevated morning adrenocorticoid level. Or D, elevated morning cortisol level. Let's review the answer. The correct answer is D, elevated morning cortisol level. Now, in this question, there were certain clues that stood out that should have made you think of Cushing's syndrome. The fact that the female had excessive hair growth, the fact that she was overweight, all these things put together should make you think of Cushing's syndrome. And as you can read in front of you, the rationale, that's the reason why elevated morning cortisol level is the correct answer. Let's do another question. Which of the following lab results is suggestive of subclinical hypothyroidism? A, elevated TSH and low T4. B, decreased TSH and elevated T4. C, elevated TSH and normal T4. Or D, normal TSH and elevated T4. Let's review the answer. The correct answer is C, elevated TSH and normal T4. Another thing that the Cohen review does is that we have lots of visuals and graphs to help you understand things like TSH and TSH levels. It is your job to feel very comfortable in the exam answering questions in regards to TSH results. So you have to know when the interpretation is for hypothyroidism, hyperthyroidism, and subclinical hypothyroidism. In addition to that, you have to know when you would change medication. For example, if the TSH is low, what would you suspect? What if you have the T4, you don't have the T4 value? What would you do? When do you go up or down in medication? These are things that you should be ready to answer entering the exam. And yes, the Cohen review goes over all of this in this particular topic with a graph, which is a great visual. Next question. A 48-year-old female has a fasting blood glucose of 136 on 2 separate occasions. After discussion, she agrees to starting on metformin. What is the mechanism of action of this drug? A, decreases hepatic glucose production and increases peripheral glucose uptake. B, it enhances insulin production by pancreatic beta cells. C, lowers renal glucose threshold and increases glucose excretion in the urine. Or D, stimulates pancreas to secrete insulin in response to meals. And the correct answer is A. Metformin decreases the hepatic glucose production and increases peripheral glucose uptake. I highly recommend that you review all the diabetes medications, all of the classifications, side effects, what organ function to assess while they're on that medication, because this is known to show on the exams. Metformin, particularly, it's a very important drug that you should become familiar with simply because we see it in primary care quite often, and that's what the test is testing for. Primary care level nurse practitioner. So metformin being the first drug that we prescribe to our diabetic patients, it's one that you should know very well. Which leads us to the next question. Which of the following is the most common adverse effect associated with glucophage, also known as metformin? A, weight gain. B, diarrhea. C, lactic acidosis. Or D, hypoglycemia. And the correct answer is diarrhea. Metformin is known to cause GI issues and disturbances. So as nurse practitioners, we educate our patients on the common side effects so that the patient doesn't freak out. Again, can't stress enough the importance of reviewing the diabetes medications, primarily metformin. Understand when it's prescribed, how much is prescribed, maximum dose. Next question, still on the endocrine topic. A 26-year-old female with a BMI of 33 has a rash on her neck and axilla On examination, there are thickened, velvety, hyperpigmented plaques in these areas. What is the most appropriate test to order? A, complete blood cell count. B, hemoglobin A1C. C, punch biopsy. D, thyroid stimulating hormone. The correct answer is B, hemoglobin A1C. And this is known as acanthosis nigrans, which is something that you'll see with our diabetes patients. In the AANCC, you will see pictures. They may show you acanthosis nigrans like this picture that I have in front of you. The AANP may describe this particular finding, and it is your job to understand that it's related to diabetes and that the proper test to order would be a hemoglobin A1C. Additional topics covered in the Cohen review in regards to endocrine would be your hyper or hypothyroidism, Graves' disease, Hashimoto, Addison's, lots of diabetes medication management. Other topics that you should feel comfortable with or scenarios. Do you know what a thyroid storm is? Do you know what toxic multinodular, Do you know what toxic multinodular goiter is? Do you know its signs and symptoms? Are you familiar with smoky versus dawn phenomenon? And I'm proud to say that I do a really good job at teaching dawn versus smoky effect for the diabetes. And again, I welcome you to see that lecture on endocrine in the Cohen review. Orthopedics. A 49-year-old female with a history of hypothyroidism and diabetes type 2 presents with right shoulder pain, stiffness, and decreased movement for several weeks. She denies any recent or remote injury or overuse of the extremity. On exam, there is reduced active and passive range of motion with forward flexion, abduction, and internal and external rotation. What is the most likely diagnosis? A, adhesive capsulitis. B, osteoarthritis. C, rheumatoid arthritis. D, subacromial bursitis. The correct answer is A, adhesive capsulitis. And I'll take the opportunity to introduce to you my style of teaching. I like things to make sense to students or to make sense to me. And sometimes I find funny ways of teaching things that would, in my head, and I hope in students' heads, at least that's what they tell me it works, of things, how to connect things so that they make sense on the exam. So in this case, adhesive capsulitis, I want you to think of diabetes as having too much sugar in your blood, which is the case, and think of sugar as being sticky. Now, what would happen if there's sticky blood in your joints? Things will get sticky or stuck together, hence the word adhesive. Now, capsulitis in regards to the shoulder, so it's a sticky shoulder, it's hard to move, and I want you to associate that with diabetes, hence the question which described the lady having diabetes. This is also known as your frozen shoulder. So again, finding ways and associations of things, trying to make it as easy as possible for you to remember things. That is my style of teaching. And this is what students say works very well for them when they're studying for the boards. Next question in orthopedics. Which of the following findings is helpful in the diagnosis of de Quervain's tendinopathy? A, positive Allen's test. B, positive Finkelstein test. C, positive Fallon sign. Or D, positive Tinnell's sign. And the correct answer is B, a positive Finkelstein test. There's lots of names that you will encounter during your studies. And orthopedics is a huge topic on its own. Finkelstein, Fallon, Tinnell, Allen. You can mention McMurray, Apley's maneuver, anterior drawer test, all these names of maneuvers and tests. Yes, you do have to know them all. And again, an image, I think it's worth 1,000 words. So Finkelstein test is when you put your fist in that way and you hyperextend, causing some issue, some tenderness, some pain on this particular area. Fallon, it's classic for the carpal tunnel syndrome. Tinnell's test, also for carpal tunnel, and Allen test has to do with circulation. Next question. Which of the following is true regarding rheumatoid arthritis of the hand? A. Bouchard nodes are present on the pip joints. B. Dip joints come before pip joints. C. Heberden nodes and mucous cysts are common. Or D. Is typically unilateral. The correct answer is Bouchard nodes are present on the pip joints. Please make sure you understand and you feel comfortable differentiating between pip joints, dip joints, Heberden nodes, Bouchard nodes, and understanding which condition has which. Would you happen to know which condition will have both nodes, Heberden's and Bouchard? If you don't, make sure you review this topic in the Cohen Review lectures. A 42-year-old female complains of pain at the base of her foot between the second and third toes. She states, "It feels like I am walking on a pebble. There is pain and numbness when she walks, which is relieved with rest. Which of the following is the most likely diagnosis? A. Morton's neuroma. B. Metatarsal strain. C. Plantar fasciitis. Or D. Stress fracture." The correct answer is Morton's neuroma. Now, I would like to share with you that during your studies for the nurse practitioner boards, there will be diagnoses, scenarios, cases where a description is very specific to that particular diagnosis. In this case, Morton's neuroma. And that's a good tip that I want you to take home. Nothing that I can think of for the purposes of studying for the nurse practitioner boards will be described as numbness and tingling to the third and fourth toe with feeling like you're stepping on a pebble other than Morton's neuroma. And I make sure to point these things out during the Cohen Review lectures so that you are very well aware when you're reading a question on the exam that talks about, in this case, a pebble, like you're stepping on a pebble, third and fourth toe numbness, your diagnostic antenna during the exam will go up for Morton's neuroma, and you will be looking for the answer that it's related to Morton's neuroma, if not the term itself. And that's another thing that students find very helpful. I tell you specific things to focus on during your studies so you won't miss them on the exam. Plantar fasciitis, a very common topic on the primary care level, nurse practitioners. So very important topic that I want you to be ready to see on the exam. Where do you think the pain is located? Who do you think suffers most from this? When is the pain worse? And what do you think are the treatment options? Well, let me review these with you here, and I hope that you know the answers to these. So plantar fasciitis is an inflammation of the plantar fascia, the tissue in the foot used during walking and foot movements. Pain and stiffness is mostly at the bottom of the heel, hence the picture I have in front of you. You see the redness? That's where it's mostly affected and felt. Now, the people who would suffer most from this would be obese patients, because think of it, lots of stress on that location. So too much weight would do this. Runners, from the same idea, pounding on that area. Jobs that require prolonged standing for the same reason. Poor fitting shoes. Women. High or low foot arches. Now, I also like to give scenarios or either things that have happened to me during practice or personal life, because students say that this helps them remember and associate topics. Now, I clearly remember being pregnant and suffering from plantar fasciitis. Why during pregnancy? Well, because we have a hormone during pregnancy that it's released, which causes your tendons to soften up so that the baby eventually can come out of the canal, the hip canal. Relaxin, it's called. And because it's a systemic hormone, it affects every single tendon. So pregnant women will also suffer from plantar fasciitis because of this. And that's a good way to remember pregnancy and plantar fasciitis. Once the baby is born, relaxin is no longer excreted, so plantar fasciitis resolved. Now, when is the pain worse? At night, after all that repeated stress on that area from the day. And treatments will include RICE, remember RICE? Rest, ice, compress, elevate. Physical therapy, braces, splints, cortisone injections, orthotics, NSAIDs, massage, even changing the shoes.